Chapter 25, Bleeding. We're going to talk in this chapter about recognizing bleeding, understanding why bleeding is important to both recognize and treat, and to talk about what happens when bleeding is not dealt with appropriately. We have to understand that bleeding can be external and internal, and of course external being easier to recognize, but we still have to be able to recognize the signs and symptoms of internal bleeding, recognizing the issues that arise when bleeding is occurring and isn't being taken care of. So bleeding is a problem with the cardiovascular system. There is a break in the pipes that is causing the blood to leave the system and enter into other parts of the body. So we know that the cardiovascular system circulates blood and oxygen and removes waste from the body. It delivers the oxygen and the nutrients to the cell and then carries away all of the waste products. So we have to keep the function in mind when we talk about when that function is failing. So this picture shows the different parts of the cardiovascular system and circulatory system, recognizing the pump being the heart, the container or the pipes being the blood vessels, and the fluid being the blood and the body fluids. The blood, of course, having the red blood cells, the white blood cells, the platelets floating around in the plasma. Of course, in the picture, anything that is blue is deoxygenated, anything that is red is oxygenated. The heart is the pump and relies on rich and well-distributed blood supply. So it not only needs its own supply of oxygen, but it also needs a good blood supply to enter into the chambers in order to push that good blood supply around and provide the body with what it needs. It does this working with two paired pumps, the upper chambers, right and left atrium, and the lower chambers, the right and left ventricle. Each chamber between the right atrium and right ventricle, and between the left atrium and the left ventricle, you'll find a one-way valve. This prevents backflow so that when it goes from the right atrium to the right ventricle, it stays there and the blood from the right ventricle does not seep back into the right atrium. So this picture on the left is showing you where the deoxygenated blood and how it travels. And this comes in from the superior and inferior vena cava, which brings in oxygen low or oxygen poor blood from the upper and lower part of the body. And that blood then goes into the right atrium. From the right atrium, it gets pushed into the right ventricle. And then from the right ventricle, that blood is going to travel through the pulmonary arteries, whether it's the left or the right, and go to the lungs. And at the lungs is where the waste is going to go back into the lungs and the oxygen is going to come into the bloodstream. So gas exchange is occurring there. And once that gas exchange occurs, the pulmonary veins, so the right and left pulmonary veins, bring the blood back, and the blood is coming into the left atrium. It is red because it is oxygen rich. From the left atrium, it's going to go into the left ventricle, and from the left ventricle, it will go into the aorta, and the aorta will pump it into the rest of the body. What you see in that picture on the right at the top with those three arrows pointing up, one of those is going to feed into the cardiac arteries. One of those is sending that oxygen-rich blood directly to the coronary arteries, and the rest is going to the upper part of the body. So again, right side is oxygen deficient, left side is oxygen rich. So when you look at the pipes or the vessels, remember, and this should all be a review, that the arteries carry blood away from the heart. The arteries are oxygen rich and they carry blood away. And the way to remember that is arteries and away both start with an A. The arteries are the largest vessels going away from the heart. They then go into a smaller vessel called the arteriole. And from the arteriole, we then get into the capillaries. The capillaries kind of meet and link the arterioles and the venules. And remember, the capillaries are where you are getting gas exchange occurring at the cellular level. So that's the oxygen-rich flow of blood. From the capillaries, we then go into the venules. Once that gas exchange has occurred at the cellular level and my blood supply is now full of the metabolic waste, it's going to travel into the venules, which are thin-walled vessels, and then go into the veins, and then from the veins, it's going to go into the heart to allow for the gas exchange to occur at the lungs. This picture here shows you the process of gas exchange, whether or not it is in the lungs happening at the alveoli sac, or if it is in the body happening at the cellular level, gas exchange diffuses through the capillaries. We remember that blood contains red blood cells, and the red blood cells are responsible for the transportation of the oxygen and to the cells and the carbon dioxide away from the cells. The red blood cells, as a reminder, are what are deformed in sickle cell. Red blood cells, unfortunately, can't tell the difference between oxygen and carbon monoxide or some other chemicals. All they know is that they are the taxi cab and they need to have a passenger. Our goal is that that passenger is oxygen or carbon dioxide. We also have white blood cells and platelets. White blood cells help fight infection. Platelets help form blood clots. That picture is actually just a slide of blood showing you the different parts, the white blood cells, the platelets, the red blood cells. And those three are going to be carried in plasma, which is the liquid aspect of the blood. We need blood clots to form. Blood clots form based on the need, recognition of change in the vessels, based on homeostasis of the blood, so that it's got the right balance of platelets, red blood cells, and white blood cells, and also based on the ability to clot, based on not having any medications that are designed to minimize clotting, or having disorders like hemophilia that impact the body's ability to clot. Because what happens is, as soon as a tissue is injured, the body is going to send platelets to that injury site. And the platelets' goal, again, is to become sticky so that the red blood cells then stick together. So the platelets cause the red blood cells to become sticky so that they begin to clump and form a tight, basically a tight weave, so that bleeding will slow and eventually stop. The autonomic nervous system actually plays a role in this. By monitoring the body's needs every second of every day, it can adjust as needed. So if I have a bleed, it will adjust blood flow. It will redirect blood from less important areas to more important areas of the body to protect us. So if I have a bleed, and there is the potential for poor oxygenation, my body will redirect blood away from other organs, such as, or even other cells. So I may not get the best blood flow to my fingers or my toes because my body, my autonomic nervous system, is recognizing that the heart, brain, lungs, and kidneys need support. The autonomic nervous system allows the body to balance. And when it cannot help maintain homeostasis or perfusion, when the body is having too much trouble, we then get emergent situations and our patient increases the likelihood of going into shock. As a reminder, perfusion is defined as circulation of blood within an organ or tissue to ensure appropriate levels of oxygen, nutrients, and waste removal. So perfusion is the circulation of blood to ensure delivery of oxygen and nutrients and removal of waste. And perfusion occurs at the cellular level. But it takes ensuring that the pump and the pipes and the blood are doing their job so that that adequate level is maintained. We have to have appropriate blood flow. So it's got to be at a good enough pace to maintain circulation. So there's got to be good force, but it can't be so fast that gas exchange cannot occur. So if the red blood cells are being forced through the capillaries too quick, the oxygen can't depart and the carbon dioxide cannot get on it for that exchange to occur. So we have to make sure that while they may be perfusing, determine whether it's adequate or appropriate for what they need to support life. And some of the need for that autonomic nervous system balance is because every tissue in the body is different regarding its ability to survive without oxygen and for the length of time. So while some parts of our body are better prepared and can kind of hold on longer, other parts are going to start to die very quickly if oxygen supply is not regenerated to those cells. The entire body, every aspect of our body, requires adequate perfusion. We can go, again, without some oxygen to some of our cells for a while, but eventually, and it's normally a short eventually, if oxygen supply and perfusion is not fixed, we will see function loss, change in mental status, and potentially death. And our goal is to provide the appropriate emergency care to ensure adequate perfusion until we can get them to the hospital for more definitive care. We know that the heart requires a constant supply of blood. The minute that oxygen, and not just blood, honestly, a constant supply of blood that has an appropriate balance of oxygen and nutrients and is able to then remove waste. The brain and the spinal cord can go for 4 to 6 minutes before we start to see long-term impacts. The lungs can survive 15 to 20 minutes without getting an oxygen supply. Kidneys can survive up to 45. Muscles can last 2 hours in a healthy, appropriately temperatured adult. And each of these, of course, is going to be based on the health of the patient. Someone who has chronic health issues, a patient who has COPD, they may not necessarily be able to survive as long without oxygen to those areas. It may take less time. And so we have to be cognizant of predisposing factors that are going to negatively impact our patient's ability to compensate. First type of bleeding we're going to look at is external bleeding. And external bleeding is really easy to see. It is when blood is outside of the body. Because guess what, people? Blood is not supposed to be outside of the body. So when we talk external bleeding, we may also use the term hemorrhaging. It is visible. Okay, so external bleeding means when the blood leaves the body in any way. It can be an open wound, a cut, a laceration, penetrating trauma. It can be a nosebleed. So the nosebleed can be because their nose is dry and they're prone to it. It could be a nosebleed as the result of pressure buildup in a head wound. Could be bleeding from their ears. That's all external bleeding. Also rectal bleeding. If it's leaving the body from any opening, it is an external bleed. Our goal, of course, is to recognize patients who have severe and life-threatening bleeds. That doesn't mean that we ignore any other bleed that isn't severe or life-threatening, but if you remember during our primary assessment, one of the checks under circulation is major bleeds. We do a head-to-toe check for major bleeds for a reason. No matter what, you will treat bleeds, but our initial goal during primary assessment is those major bleeds. And you have to begin to understand what a major bleed looks like. You have to recognize that a patient who has been bleeding onto a carpet may look like they've lost less blood than the exact same patient who is bleeding on a linoleum floor. And that's because, of course, blood's going to look different on different surfaces. When you add water into blood, it may make it look like it's more blood. And so our goal is to estimate the amount of external blood loss, but not use that to make a decision whether it's critical or not. You want to look and go, oh God, that's a lot of blood, but are they showing other signs and symptoms? The typical adult male has approximately 70 milliliters of blood per kilogram of body weight. So some of blood loss and some of the not tolerating greater than 20% of blood volume is going to be based on the patient's weight. Bigger patients, more blood. So typical adult male has 70 milliliters per kilogram. The typical adult female has 65 milliliters per kilogram. When you have a patient who has significant blood loss, we would expect to see changes in their vital signs. Now, just like shock, when we have blood loss, our initial reaction is going to be some compensation, and that's where we see those initial changes in our vital signs. So when my body recognizes that I have a bleed, especially a significant one, I'm going to see an increase in the heart rate, because basically my body is saying, something's wrong. I'm not getting the oxygen I need. You know what? I need to pump it quicker. It's not that I'm bleeding, it's that my heart's not doing a good job. So let's do it quicker. And it's going to say, you know what? Maybe I'm just not breathing enough, taking in enough oxygen. So let's do that more. And then we're going to see a decrease in the blood pressure, because as the autonomic nervous system believes there's a need for more, it's going to widen that blood vessel to try to let more blood flow at once. So we'll see, again, increase in heart rate, increase in respiratory rate, and a decrease in the blood pressure with significant blood loss. Because infants and children have less blood volume to begin with, it takes less blood for them before we start to see those signs and symptoms. So understand again, 20% of the body's blood volume is significant. So that's actually going to be less in our infants and children than it is in our adult patients. How we compensate is based on how rapidly we bleed. If you donate blood, you know that they try to actually not let you bleed too quickly. So if your goal is to, be done 10 minutes, I can donate a liter or 1 unit of blood in 10 minutes. They're probably not going to let you because you cannot necessarily recover appropriately. So an adult can comfortably donate 1 unit of blood over a 15 to 20 minute period. However, if that happens over a shorter period of time, so I lose 500 milliliters in 5 minutes because of a significant bleed, I'm going to start to show signs of hypovolemic shock. And as we've said, age and pre-existing health conditions are going to affect how well I compensate. And it's also important to recognize that even if I'm compensating when you get there, if you don't act quickly and see this as a significant issue, I'm not going to compensate anymore and you'll have to catch up. So recognize that a significant external bleed should be treated quickly regardless of how well my patient is handling it. So where will we see external bleeding? So significant MOI is when I'm going to consider the potential, when I'm going to see it. Patient with a poor general appearance that is calm, someone who has external bleeding, I would hope that if you saw significant blood loss from yourself, you'd kind of start to get upset, maybe a little anxious. So if you're not anxious, obviously that's a problem. External bleeding can cause shock, and hypovolemic shock, volume. So patients may and likely will have signs and symptoms of shock. When I see the blood, I should assume they are bleeding. A wound that is causing rapid blood loss and uncontrolled bleeding. All characteristics of somebody who has a wound causing external bleeding. If it is an arterial bleed, so it is blood from an artery, pressure causes the blood to spurt every time the heart contracts. So if you haven't immediately applied direct pressure, when you approach this patient, every time their heart beats, blood will spurt out of the wound, normally bright red. If you didn't stop the bleed, you could count their pulse by every spurt. But yeah, don't do that. That's a bad idea. So arterial bleeding is spurting. Venous bleeding, blood from the vein is going to flow. So it's going to flow rapidly if it's a bigger vein, slowly if it's a smaller vein. It's not going to spurt, and actually is easier to manage, where spurting blood can push a clot and can be harder for the platelets to control and to build clots in. Bleeding from the veins, venous blood, is going to be easier to slow because it is a constant pressure. So the platelets can kind of make changes and adjust based on that pressure. So arterial, bright red, spurting. Venous, dark red, and a steady flow. And then we can bleed from our capillaries. Capillary bleeding is an ooze, and it's steady. It's a paper cut. So that picture in the bottom corner of the hockey player, he actually took a skate to the neck. And you can go YouTube ice hockey skate to the neck. But capillary bleeding is less life-threatening. If you've ever had road rash, or if I played volleyball and I used to just damage my legs on the floor and it oozed. So it's a steady ooze, not normally life-threatening, because you're damaging the capillaries. The problem, of course, is gas exchange happens at the capillaries, so now you've got damage in that area. We want to clot. Our goal is that our body maintains homeostasis so that we can clot. When we're doing what needs to be done and the bleed isn't significant and the body is functioning appropriately, we can clot and get our blood, our external bleeding to stop normally within about 10 minutes. When the blood, when our skin has broken and the blood is flowing rapidly, our body starts to kick in. And so what ends up happening is the cut begins to narrow as the clot forms. Bleeding doesn't stop though if that clot doesn't form, even if you're putting direct pressure on it. One of the things we do with direct pressure is to really slow and minimize the size of the vessels to let the platelets get in there to form a clot. However, in certain situations, it is likely that our body can't compensate appropriately, can't work, and therefore won't appropriately or effectively clot. Some of those, if you move, if you've ever got a paper cut or cut right there in the bend of your finger and you've straightened your finger, it may start to ooze again. Certain diseases like hemophilia cause clotting deficiencies. Certain medications thin the blood, make it harder to build clots. If you remove a bandage, if you take a Band-Aid off a paper cut too soon, it will continue to bleed. Things like the external environment, if it's too hot, too cold, rainy, body temperature, and a severe injury. A patient who has massive wounds, jagged cuts, the body may not be able to react and work efficiently and appropriately. We have talked about hemophilia. You know that hemophilia is a disorder in which the patient is unable to develop clots. So they don't have platelets, they don't have the clotting factors. Unfortunately, in these patients, the bleeding may occur spontaneously. So, a bump where you and I might, well, maybe just me, run into a door jamb because we don't turn far enough, wide enough, that may cause a life-threatening injury to a hemophiliac. So those patients both carry medication to take and also are advised to go get additional treatment, regardless of how minor it appears. So that's external bleeding. Let's talk about internal bleeding. Internal bleeding is when there is bleeding in a cavity or space inside the body and the blood does not leave the body. Our biggest concern with internal bleeding is that it cannot be easily detected and may be something that has occurred for over a period of time and become more significant before the patient even realizes there's a problem. And just like external bleeding, internal bleeding can cause hypovolemic shock. Some of the possible things and causes that may result in internal bleeding: broken bones that haven't broken the skin, so the broken femur, any closed fracture has the possibility where those bone ends can slice through vessels. Stomach ulcers can cause internal bleeding, lacerated liver, spleen, pelvic fractures. If you have a wound to the lung, again, a hemopneumothorax can be internal. So any injury, a bruise that doesn't have an opening is internal bleeding. So anytime there is bleeding but there's no opening in the skin allowing the blood to come out, it's internal bleeding. How can we get internal bleeding? Well, any high energy mechanism of injury, should increase your suspicion that they may have internal bleeding. Any blunt trauma can cause internal bleeding. When we talked about blunt trauma, if you've listened to that lecture, you'll remember I talked about backing into the trash can so that when the trash can's popped back out, it doesn't look damaged, but whatever was in the trash can may have been crushed. And blunt trauma can do that. And when there is no opening from the outside to the inside, then there's no way for the inside to get outside. So, blunt trauma is going to cause internal bleeding likely. How do we know there's internal bleeding? Well, that's what DCAP BTLS is for. How do we know to be concerned about internal bleeding? DCAP BTLS. So if there's a deformity, it's increasing our suspicion that it is a fracture or dislocation, which increases the likelihood that they have internal bleeding. A contusion is an internal bleed. Abrasion may not have broken the skin necessarily. Punctures. So if I have an impaled object, I've been stabbed and the knife is still in place, it is possible that I am bleeding internally. Burns. Burns are less likely to cause internal bleeding, but might. If you have tenderness to an area, especially in the abdomen, that's where I'm going to be concerned that maybe there's some bleeding. Lacerations and swelling. And some of these may also cause external bleeding as well. But it's not always a traumatic injury that's going to cause internal bleeding. Someone who has a gastrointestinal bleed, bleeding from ulcers and colons, a ruptured ectopic pregnancy, and then an aneurysm. None of those are traumatic in nature, but they do cause internal bleeding. So some of the frequent signs that we see with internal bleeding and non-traumatic injuries are the abdominal tenderness, guarding, rigidity, so tightness in the stomach, in the abdomen, pain, and distension. Because most of our internal bleeds that are non-traumatic are going to be in the abdominal cavity. Other signs and symptoms might include dizziness, faintness and weakness, vomiting of blood or complaints of bloody diarrhea or urine are going to be huge signs that your patient likely has a bleeding ulcer or other gastrointestinal problems.